Thank you, Dr. Jinbai and Dr. Cho. So since the clock is ticking, let's move on to the final lecture for today. Let's welcome the moderator for our last lecture, Dr. Hongyi Cho, Director of CCHP, President-elect of APATH. So let's give a round of applause for Dr. Cho.
Okay, our last speaker, but not the least, I will welcome the Professor Chang Yun. Professor Chang Yun is a radiologist. His major clinical expertise in cardiothoracic and breast image, and he also have been trained in the Duke University about the radiology fellow. And the most accomplishment in hospital, he built up the CT guided core biopsy of lung region, and also the CT guided localization for VATS in the National Taiwan University Hospital. Now the Professor Chang holds his position in Chief of Cardiopulmonary Imaging Department of Health Imaging, National Taiwan University Hospital, and also the Chief of Community of Thoracic Imaging in the Taiwan Radiology Society. And today, he will talk about early detection of lung cancer, the experience from the clinical trial to population-based lung cancer screening program in Taiwan. Let's give the big pause for welcome the Professor Chang.
Good afternoon, ladies and gentlemen, distinguished speaker and the chairman. It's my greatest honor to give this talk because in front of many epidemiologists, I have been exposed to some terms I have never been known. So I Google a little bit. I think it's important in the healthcare. My topic today is discussing the early detection of lung cancer. You can see that on this picture, this is the pathology of the early lung cancer, and it can be recognized as a small ground glass nodule in the lung. So this kind of lesion representing early lung cancer, and it cannot be recognized on the routine chest radiograph. So I have no disclosure. I'm going to discuss some risk factors of lung cancer. Lung cancer screening focus on heavy smoker, as many speakers talk. Lung cancer in never smoker, the current evidence, and the national lung cancer screening program in Taiwan. So this slide shows that the Asian actually has the highest global health burden of lung cancer compared to many other regions in the world. So there are many common risk factors of lung cancer. And on the left-hand side, tobacco smoking, current or ex-heavy smoker are recognized as the most important etiology of developing lung cancer. However, there are many other factors that maybe we should be aware of these factors so that we can find out more lung cancer. In traditionally, I think that lung cancer is recognized complications of smoking. It is estimated to account for nearly 90% of lung cancer. But other factors of lung cancer should be recognized. On this table, we found that there are many listed randomized clinical trials from the top to the bottoms. The recruitment eligible criteria actually all focused on the heavy smoking. These two randomized clinical trials are the most famous two, published in the New England Journal in 2011 and 2020. On the left-hand side is NLST's clinical trial, which is the first randomized clinical trial to show the power of low-dose CT has the capability of a lower lung cancer mortality by 20%. However, using their size criteria, there is a higher false positive. On the right-hand side is a Nielsen trial. It is a Netherlands Belgium study. They also show the power of the low-dose CT compared to chest radiograph can lower the lung cancer-related mortality by 25%, but they have a less false positive. They used some method. So this table shows the lung cancer number more detected in the low-dose CT, but they have less lung cancer deaths compared to the chest radiograph. So they can use lung cancer to screen the heavy smoker to reduce the mortality. Nielsen trial also showed a similar effects. So the most important thing is the stage shift. If we use low-dose CT screen lung cancer, we can find out more early-stage lung cancer in the screening group. Therefore, we can treat them earlier, and we can save their life and decrease the lung cancer-related mortality. So smoking is considered the most important risk of lung cancer. There are the USPSTF, they have announced this, and it is also in the recognized and endorsed by many professional societies. So it is 50 to 80-year-old, 20 packs a year for quitting smoking less than 15 years are candidate for lung cancer screening in the heavy smoker group. However, the difference of lung cancer in never smoker, actually, the number is rising. These two review articles show that they review that smoker and non-smoker are actually different in many ways, including there are more non-smoker lung cancer in female, and the genetic mutations are also different. Non-smoker lung cancer at the initially found at the first diagnosis usually has stage 4 advanced disease. So the proportion of lung cancer among never smoker actually increases. It is a global phenomenon, especially in the female. Female in the Asian population actually has a higher proportion of lung cancer. So never smoker were likely to be female. Never smoker lung cancer more likely to occur in female and younger than the smoker. So this is a very important phenomenon that we found. In Taiwan, I think the 63% of diagnosed lung cancer did not have the smoking history, and 94% of female diagnosed with lung cancer have never smoked. The similar report in Republic of Korea, they have also a significant portions of the never smoker lung cancer. So as we know that the early lung cancer will have a better prognosis. This is a data from National Taiwan University. On the left-hand side is the total lung cancer. On the right-hand side is the lung cancer last selected can be operated. Both early stage has the best survival, but those who selected the patient, even with the advanced stage, they can operate it, they have a better survival than those who cannot be operated. So finding out the early lung cancer is a very important issue in the lung cancer screening. This is female lung cancer in Taiwan. Male lung cancer in Taiwan. So the lung adenocarcinoma increase, the squamous cell carcinoma decrease. And female has a more larger slope. So you can find that lung adenocarcinoma is a predominant type and the squamous cell decrease. So if we combine the figure together, you can find that the situation, actually the female lung cancer increases, especially in the histopathology of lung adenocarcinoma. Squamous cell pathology decrease because squamous cell is considered as the result of smoking. So after the smoking cessation campaign, so the squamous cell lung cancer decreases. So at the point of 2014, the female lung adenocarcinoma exceed the male lung adenocarcinoma. So there are some characteristics of the lung cancer in never smoker. We already know that the screening in the heavy smoker population had a benefit using low-dose CT, but currently the screening guideline, according to the NLST and the Nelson trials, the eligibility criteria can miss more than 50% of lung cancer. And this phenomenon should be considered seriously in the Asia country. So we should look at the other risk factor for lung cancer. This study had this slide had many rows, but actually these are the data they derived, they used. They found that lung adenocarcinoma is higher among female than those with male. So, so never smoker lung cancer is increasing, so we have to focus on looking at the high-risk populations. So I will show some papers study in Taiwan. So we will show the situation in Taiwan. In this study, there is an association between breast cancer and second primary lung cancer among patients, female populations. If we compare two groups, the first group is the no breast cancer, and those with breast cancer. So in the cohort of patients with breast cancer has a higher incidence of developing second primary lung cancer. Air pollution is also an important issue. This is a study published by Professor Chang's groups. So they studied the nationwide air pollution regarding the long-term PM 2.5 exposure. This is a very long period studies that use the weather station information to correlate the visibility of the map and also correlate the registration of lung cancer in different areas in Taiwan. So the results show that this is the increase in the incidence of lung cancer and the visibility of the land from the weather station actually correlate with the environment. The rural area has a lower cancer incidence compared to the urban area. Gene is also a significant factor, including they have a 25 selected loci from the genome-wide study. They show that there is a stronger association of this selected loci in the gene in the never smoker, which compared to the smoking populations. Polygenic risk score, environmental tobacco score, and the lung cancer are also related. You can see from this study there is higher absolute risk in the group has both exposure of tobacco at home and work. And if you have a two single exposure and you have a longer percentage, then you will have super addictive or synergistic effects. So tobacco, environment, and gene are actually related. There are some studies in Taiwan show that the family history of lung cancer actually increase the risk of the lung cancer. So for the simplex cases, it means that has a family history of lung cancer only one subject. Multiplex show is defined as more than two members of a family member with lung cancer. So multiplex family has a much higher lung cancer detection rate. And this phenomenon is more evident in the never smoker compared with to the smoker. There is also some mother and mother relatives, maternal relatives factors. So if the lung cancer is in the mother and maternal relatives, they are relative higher risk of developing lung cancer. So this is a very distinct feature in the family history of lung cancer. And I think that this study is a very important study, talent study. Talent study was conducted by Professor Pan Yang, and this paper actually has a great influence of the national lung cancer screening in Taiwan now. Because they study the Taiwan lung cancer screening for never smoker, it's involved 12,000 participants divided into two arms. The one arm is a never smoker with no family history, and the other arm is a family history of lung cancer. So they found that there is overall lung cancer detection rates higher in those with a family history of lung cancer. They use different criteria compared to the lung rate now. This is a definition. In using this definition, the positive findings are more ground glass nodule, which means no solid part. The nodule is like a ground glass and not obscure the underlying bronchovascular bundles. The age, increased age is also the risk of developing lung cancer. Talent study starts from 2016, and I think it is for many years study, and we know that Korea is the first country to do in lung cancer screening in Asia, but Taiwan is the second one. But Taiwan has including different subjects, family history of lung cancer. So till now, there may be around 200 hospitals participating for lung cancer screening, and until this year, this May, there are more than 10,000 eligible subjects were scanned. So the age range is younger than the in other countries. It's 50 to 74, 45 to 74 in family history, and 50 to 74 in heavy smoker. But I heard that they will lower the enroll criteria 5 years earlier. So this is the eligible criteria and some requirement, including a CT scanner. We required more than 64 slides and some other rules, structural report, and there is a modified lung rate for interpretations. This is the previous edition of lung rate version 1.1, and there is a latest lung rate 2022 published after we start to national lung cancer screening. So this is the edition one earlier than the current lung rate study, but there are some modifications majorly focused to adjust the threshold of a non-solid nodule, so-called ground glass nodule. Nodal CT screening actually is to detect any nodule, measure their size, volume, the type, and then we can also find some additional findings. If there are some special suggestive finding of malignancy, we will have a different category. Category 3, 4A, 4B, 4X are considered as a positive results. So this is the recently result. So the overall cancer detection rate actually is about 1.5%. And the family history of lung cancer actually has a higher incidence of lung cancer compared to the heavy smoker group. Most of the lung cancer detected in the lung cancer screening were stage 1. It's more than 80%. most of the lung cancer were lung adenocarcinoma. So this is the first year's result, preliminary results. So family history is proven to be an important enroll criteria in our national lung cancer screening programs. So you can find that even the simplex family, the participant from simplex family is more than the multiplex family, but the cancer detection rate is much higher in the multiplex family compared to the simplex family. So I think the AI, as mentioned in prior speaker, is a very important tool. It's also true in lung cancer screening. I think it will have a large impact of lung cancer screening, diagnosis, and management, not only in the imaging detection and reporting, but also in the new latest model of the scanner. They also apply some AI technique to reduce the radiation dose. So detection, characterization, and even after diagnosis of lung cancer, it is very useful for monitoring the treatment response. This is the products of the AI tool, so we can confidently detect the nodule and automatic producing the report. So this is my final slide. According to the evidence of increasing never smoker lung cancer screening strategy for never smoker with high risk factor should be initiated. From the clinical trial to population-based lung cancer screening, it shows a rationale for adopting family history of lung cancer as a criterion of lung cancer screening. So a risk stratification model may be important. In the future, maybe we are able to include in some factor from the air pollution polygenic risk model and some selected patients such as breast cancer subject. Especially thanks to the support of Professor Yang and the Health Promotion Administration in Taiwan and many of my colleagues, they have a great contribution for this data. Thank you.